Regulating the pressure in your eyes is really important for their long-term health. In this episode of OCuTALK, ophthalmologist Benjamin Stevens will be explaining the risk factors for glaucoma, the treatment options available, and what to expect long-term. Dr. Stevens?
I want to talk to you.
Not now, later.
No, now.
Hello and welcome to OCuTALK. Today we're going to be talking with Benjamin Stevens, an ophthalmologist out of California. Hello, Dr. Stevens. How are you today?
I'm good. How are you doing? Good,
thank you. To start us off, can you tell us a little bit about your background and your specialty?
Sure. I'm originally from Oklahoma. Grew up there and did my undergrad and medical school in Oklahoma. I then went out to West Virginia University for my residency. And after residency, during the end of residency, I got interested in glaucoma, but I knew I wanted to be a general ophthalmologist. So I ended up practicing in Tulsa for 5 years after that, Tulsa, Oklahoma. And I got to work alongside a really great glaucoma specialist there and kind of hone my skills in glaucoma and learn lots of new treatment modalities and gain a lot of skills there in treating glaucoma. And then about a year and a half ago, relocated here to Southern California.
Nice. We're based out of Texas, so not far from Oklahoma. Yeah. Nice. Well, fortunately for us, the topic we want to talk about today is glaucoma. So tell our audience what glaucoma is, please.
The big picture for glaucoma is the 10,000-foot view is that an elevated pressure inside the eye can cause damage to the optic nerve that connects the eye to the brain. When you have damage to the optic nerve from glaucoma, it affects the peripheral vision first. And then later on in the disease process, it can affect the center of the vision. It can even result in blindness. Understanding glaucoma, it's really important to understand the drainage system in the eye. The eye produces fluid in what's called the ciliary body to essentially keep the eye inflated. That fluid flows around the lens in the eye and through the iris or your pupil, and it goes out through a drainage system in the corner of the eye that sits between the iris and the cornea. That's called the angle. And in the angle sits the trabecular meshwork, which is the surface of the drainage system, which is like a spongy tissue that's the top of the drain. And then behind that sits Schlemm's canal, where the fluid goes through the trabecular meshwork into Schlemm's canal, and then into these collector channels, and finally gets absorbed into the blood vessels around the eye. So that's kind of how the eye keeps itself, maintains a steady pressure.
So what causes glaucoma? What makes that pressure off? What causes it to not be stabilized the way it should be?
So there are different reasons that the pressure can go up, and so that's sort of how we classify different types of glaucoma. The most common type of glaucoma is primary open-angle glaucoma, where the drainage system is open, the trabecular meshwork and things look fairly normal. However, it's not functioning as well as it should, and there's kind of a backup of the drain, and the pressure can rise inside the eye. And that causes eventual damage to the optic nerve. There are other types of glaucoma, like angle closure glaucoma, where the drainage system in the angle closes off or scars down, and that can cause the pressure to rise because it's physically blocked. There's neovascular glaucoma, which is where abnormal blood vessels in the eye grow, and they grow into the drainage system, kind of like roots growing into a drain, and they cause a clog in the drain and the pressure to go up. There's also a kind of glaucoma called steroid-induced glaucoma. That is where patients using most often like a topical steroid eye drop or something to treat inflammation in the eye, or even taking steroids, corticosteroids by mouth like prednisone. Sometimes even an inhaled steroid for a lung condition can cause this, but corticosteroids can elevate the eye pressure as well. causing glaucoma.
So is any one type of glaucoma worse than another?
Not necessarily. I would say the most emergent or urgent type of glaucoma would be acute angle closure glaucoma. That's where all of a sudden the iris, the colored part of the eye, bulges forward and blocks that drainage system, and it acutely cuts off the drain inside the eye. So the ciliary body is still producing fluid, but the drain is closed, so the pressure goes very high very quickly, and that can cause severe pain and permanent vision loss. That's something that often will take patients to the emergency department in the middle of the night because it's so painful. It's important that it's treated very quickly so that we get the pressure down, because when the pressure goes that high, damage happens fast.
So outside of that particular instance, what other signs or symptoms should patients be looking for to alert them that, hey, maybe this is glaucoma?
That's the tricky part with glaucoma. Most patients don't realize they have it. It's kind of a silent disease, or they call it the sneak thief of sight. It creeps up on people. So if you were to notice you have glaucoma, it's probably pretty advanced in the disease. It really starts way out in the peripheral vision, and it's painless. So you don't really know that this is occurring. And eventually it can affect the center of the vision. That's when patients would notice a change. And unfortunately, a lot of damage has occurred at that point. So we really want to catch it before then. That's why the importance of screening eye exams and things really helps us to catch people early on.
So are the manifestations of these symptoms different depending on what type of glaucoma you have, or is it sort of the same regardless?
The patient experiences it mostly the same based on, or for the main types of glaucoma. Aside from that acute angle closure, which is extremely painful, most other types will be sort of insidious in their onset.
So who is most likely to develop glaucoma? Is there particular type of patient, or are there specific risk factors that people should know about?
The main risk factors, so primary open-angle glaucoma is the most common type that we see. The main risk factors for that are patients over the age of 60, so age is a risk factor. Patients with a family history of glaucoma, it does and often have kind of a genetic component. And then African American patients are more likely to develop glaucoma as well. And so those are the biggies that we look for as far as screening and stratifying risk. And then when it comes to angle closure glaucoma, which has a different mechanism, Asian patients are more likely to have that, as well as Native American patients. So we see it more commonly in those populations.
Are there any preventative measures? Is there anything these people can do to try and prevent the onset of glaucoma?
Not really. There are things you can do to lower eye pressure. That some studies have shown that things like aerobic exercise, like running or cycling, are good to keep your eye pressure down. Interestingly, yoga and meditation can also lower intraocular pressure. Importantly, with yoga, doing poses that are inverted actually increase your eye pressure. So in my active glaucoma patients, I say yoga is great, but avoid things like downward dog or headstands and those kind of upside down positions, because that'll transiently raise your eye pressure. But there aren't many studies that I know of that show it as a preventive mechanism. However, it does show that it keeps pressure lower. So I think it's a positive thing to do.
That's very interesting. I've never heard that before. So when it comes to treatment options, what are the standard treatment options? Are they the same depending on what kind of glaucoma you have, or are there different protocols depending on the nature of your glaucoma?
Absolutely, yes. There are different ways to approach it depending on what's going on. Starting with primary open-angle glaucoma being the most common kind, generally patients are either started on drops or a laser treatment called SLT as primary treatment. Drops often start with one drop in each eye at bedtime. That's pretty simple. And then SLT treatment is a laser that's done in the office, where you actually gently laser the trabecular meshwork in the drain of the eye, and that enhances the outflow through the drain to lower the pressure. There are studies now showing that primary treatment with SLT laser, even before using drops, can be pretty effective. As you can imagine, with all medicines, compliance can be an issue for a lot of patients. So remembering to do something every day, it can be a challenge. So the laser is nice because it's always there, it's always working. So that's one of our favorite starting treatments. In patients with angle closure glaucoma, things might look different. You probably would start with an eye drop to lower the pressure. And the drops that we use are aimed at either increasing the outflow through the drainage system or reducing the production of the aqueous humor or the fluid in the eye. So you're either trying to turn down the faucet or increase the outflow through the drain. Another option in angle closure glaucoma is often to take out a cataract. Cataracts sit behind the iris and can push the iris forward that can kind of block the drain. So you can take the cataract out, and that often helps to open up the drainage system in the eye. Then beyond that, you start moving towards surgical options, and there's a whole host of those that we can talk about as well.
Yeah, please do. I would love to hear more about the surgical procedures attached to glaucoma. Can you tell us what those are, what they're like, when those are necessary? I would love to hear more.
Sure. So usually start with the simple things that we can do in the office, drops or laser, but if those are ineffective, we move towards surgical options. Traditionally, glaucoma has been treated with basically two types of surgery, either what's called a trabeculectomy or a tube shunt. And both of these have been around for quite some time. They're aimed at creating a new drainage system for the eye. So we're bypassing the natural drain and creating a new drain. They're really effective surgeries at getting the pressure down. However, they're fraught with difficulties and postoperative complications. So there's risk involved. And so with those surgeries, there's a lot of follow-up needed. There's more increased risk for swelling after surgery or bleeding, or even a pressure that's too low after surgery or a pressure that's too high, which can be a big problem. And that's kind of led to the development of this umbrella term called minimally invasive glaucoma surgery. And that is where we target the natural drainage system in the eye to enhance the outflow through the natural drain and try to not have to create a new drain. Those are safer, they tend to be faster, and recovery is quicker. So there are a lot of upsides to these types of procedures. However, they generally don't get the pressure as low as traditional glaucoma surgery. So traditional glaucoma surgery is not going away, but minimally invasive glaucoma surgery is a next step before you have to have something more invasive.
Okay, so what about in the most severe cases of glaucoma? Can you walk us through what that treatment would be like?
In severe cases, we're probably more likely to move towards surgical options earlier. If drops fail and there's severe glaucoma damage already present, then you need to get in and get the pressure down more quickly. You're also more likely to move towards a traditional glaucoma procedure where you're creating a new drainage system with either a trabeculectomy or a tube shunt than you might do a minimally invasive procedure, just because you know you need to get to that point quicker.
What happens if it goes untreated? Does it go untreated?
It does, unfortunately, often go untreated. Patients who don't get their eyes checked regularly and maybe have a lot of risk factors and things can come in with pretty advanced vision loss. Sort of when you get to the end of glaucoma, it's constricted the peripheral vision to the point where patients are kind of looking through a small aperture or like looking through a straw. So it can profoundly impact their life and their ability to drive and things like that. It does, like I said, often go untreated, and it can eventually lead to blindness. So it's a very serious disease, and that's just why the importance of screening is out there, and we just need to get people checked.
So for patients with glaucoma, whether they come in late or they come in early, these procedures, is it being completely repaired? Is this a curable condition, or is this a more chronic disease?
That's a good question. It is a chronic disease. So once you're diagnosed with glaucoma, you need to be monitored for life. when we begin treatment, sometimes one treatment, say an eye drop or a laser treatment that we do, that may work for a few years, and then the pressure may creep back up and that treatment's not working. So we need to try something else, add additional drops or do another laser treatment, or move towards the surgical options. So because one thing worked doesn't mean that it's done. Some patients misunderstand, and that's can be problematic. And importantly, the damage that patients incur from glaucoma is permanent. So once the optic nerve incurs damage from glaucoma, we can't get that back. So if vision is lost, generally it doesn't come back. There's hope in the future that that might change, but currently, to my knowledge, there's not any reversible forms of glaucoma.
That is really good to know. I'm glad that you got to tell us all of that. So I assume you probably have a long-term maintenance regimen for your patients with glaucoma. Can you tell us a little bit what that looks like?
Sure. In most stable patients with glaucoma, if we have the pressure controlled where we need it to be, we follow up generally every between 4 and 6 months, and you do some testing. One test is a visual field test, which measures the peripheral vision. So you're looking to make sure there aren't any further changes in the peripheral vision. And then we do scans of the optic nerve called an OCT, which measures the nerve fiber layer that goes into the optic nerve to connect the eye to the brain, and looking for any thinning or changes related to glaucoma. And that scan in particular is very precise, so we're able to measure things down to the micron and look over time at any changes. And so it's kind of like you have a lot of data that you can compare, making sure patients are stable.
Well, thank you very much. Is there anything else about glaucoma that you want to tell our audience about while we have you?
Mostly just get your eyes checked. Any patient, I think over 40, it's recommended that every few years, at least, to get just a screening eye exam and get checked out, because the earlier these things are caught, the better.
Well, thank you very much, Dr. Stevens. It has definitely been a pleasure speaking with you today.
You're welcome. Thanks for having me.